Hi, everybody. My name is Ajay Kirtane from Columbia University in New York, and really excited to be able to chair this last session of TIO, Volume 5. We have a great panel here today. We have Holger Thiele, we have Joost Daemen. My colleague and friend Margaret McEntagart is going to try to join us. She's stuck in a case right now, but we have also David Hildick-Smith. And this is a really interesting session. It's a controversy session. So there will be talks, there'll be discussion. We'll have some polling as well. We have three controversies. One's pharmacology related, the use of aspirin in what we do. We also have an imaging OCT versus IVUS session. And then we also have a talk on treatment of stable ischemic heart disease or chronic coronary syndrome. So it's going to be good. I think we'll have a good discussion because we obviously have very thoughtful and eloquent people on the panel. And I think we'll start with a polling question for the audience. And the first one's going to be about drug-coated balloons. How often should we use them? And the first is there are several answers. Only for in-stent restenosis, restricted for in-stent restenosis and small vessel disease, liberal use in all comers and alternative to stenting, and never. So if you can answer the poll, that would be great. We'll come back to that a little bit later. But let's go ahead to the first presentation, which is going to be Holger, and he's going to be talking about the need for aspirin in all PCI. Holger, this is all you, so let's go ahead. Yes? Oh, Holger's. Okay, so we have a freeze here. So I think what I'll do is I'll go ahead and give Margaret's presentation because she's stuck in a case. This will be an interesting one on IVUS versus OCT, and then we'll get back to Holger. The idea here is to talk about it. Is it controversial in terms of which one should you use, or can they be complementary? And I think that the most important thing to start off with, and we talked a little bit about this yesterday, is to use imaging and to think about the use of imaging not as an add-on to what we do, but yet essential to what we do, because we know that the angiogram is limited and that patients can benefit with good outcomes from the use of intravascular imaging. That's the way that certainly on the American College of Cardiology's Interventional Council, we wrote the statement. We considered imaging as a whole. We actually came up with a recommendation that most labs really ought to have both. But the question is when to use which and how do we sort that out? So I think the way that Margaret broke this down, which is really, really clinically oriented, as she always is to talk about various attributes of each. The resolution, the need for use of contrast, the fact that can we do co-registration, even online co-registration, the ability to use a manual mode and to look in real time, and then how the image analysis can be done, and what are the latest improvements in terms of image analysis software, such as the use of AI, and can that be leveraged in this way? You know, it's funny on the AI side, everybody always talks about AI, and every talk, you can't go to a talk without somebody talking about how good AI is. This is one of the few areas where we actually have implementation of it, and it's kind of impressive. So we'll talk about that a little bit. So first, what about resolution? I think these images are illustrative of the fact that we now have higher resolution imaging than what most people was sort of grew up with when they thought about intravascular imaging. The days of 20 megahertz IVUS, I think for many people are passing, because yes, those are easy to use, plug and play, but you don't get the same sort of resolution as you see here. And certainly OCT has among the highest resolution, although it is somewhat luminally based. You can see through calcium, but if you have a lot of plaque, you'll get attenuation, especially if there's a high lipid content. IVUS doesn't have that issue, but as on the bottom right, you see where there's calcium, you get shadowing beyond it. So the higher resolution IVUS systems exist. It's not quite the same, as you can tell just by looking at you with your eyes at one image versus another, but certainly better than it used to be. What about other things and small, things like edge dissections or the cause of stent failure? I think that everybody, we can easily appreciate on the left that that's an edge dissection. On the right, there's a subtle edge dissection, but you got to look hard to see it. You could miss it if it was happening in passing. And even with an HD IVUS system, it's better than a non-HD system, but it's not quite the same. The challenge with OCT, though, is that you can end up over-treating because not all these dissections need to be treated, but certainly from a resolution standpoint, it's superior that way. For stent failure, it depends on why the stent failed. You can see calcium behind the stent with the use of OCT. It's hard to do that with IVUS. There are other things, though, you can see with IVUS, such as the overall vessel size, which is probably better appreciated, including the EEM, than it is on OCT. But so there's pros and cons to both of these. And what you're going to end up with in this talk is the fact that I think that they're going to both be complementary and you need certain ones for other cases. Now, what about contrast use? This is probably the one that slam dunk is favored with IVUS over OCT for the most part, because you can really, with the wire, if you know where you are, you can pull back the catheter. We typically do it in an automated fashion. We step on cine at all the points of interest, so you can have co-registration live that way. It's not the same thing as post co-registration, but it does work pretty well, especially if you have another wire in place to mark the diagonal, for instance. And you don't have to use contrast for any of this. You can do it repeatedly, and especially in our patients with poor kidney function, this is really a essential technique for those to use when you're doing complex PCI. Contrast with OCT typically is required. There are new systems. This is an example of the SpectraWave HyperView system, where there's actually a saline mode that will allow vessel size calculations and beyond with saline. But in general, with OCT, you generally need to get that lumen clear, and contrast is the most tried and true way of doing it. Saline is okay, but you don't quite get the same resolution as you do with full strength contrast. One of the advantages of this particular system, and you'll certainly see changes coming soon to the Abbott system as well, is that it has a very fast pullback, so you don't have to keep that vessel completely free of blood for as long a period of time, and that's why it can be leveraged in this way. This is the example of co-registration that you can see, and this is the new Ultreon system. We saw some nice case examples of this yesterday, where what basically happens is you inject dye, their OCT run is done, and the two images are portrayed simultaneously. You do have to do a little tracing to show where the vessel is, but the AI is much better in this version than it was before. You get exactly what the image on the right is lined up with the image on the left. There's even a live sort of co-registered live fluoro feed that happens too, where you can position your stent nicely and balloons nicely. And this is a real important finding and feature because it can be done pretty much in every room. You don't even have to have a fully integrated system. You can do it with a mobile cart as well. What does it look like in terms of manual mode? Well, we can't really do that with OCT right now. You do get a live look in when you go live, but you don't get the same sort of real-time look at what you're doing as you could do with IVUS. This is a 20 megahertz catheter because, as you know, with the Eagle Eye catheter, the imaging chain is closer to the tip as compared to all the other systems. And so by advancing it into a side branch, you can actually appreciate morphology such as this, which is where the occlusion is, and it can be used for real-time CTO work. For CTOs, IVUS is generally going to be favored in the most part, one, because of the contrast issue, but two, because you can look in real time under a manual mode and determine exactly where your wires are and where your points of entry ought to be. What about image analysis? This is where the AI starts to shine. This is real-time application of artificial intelligence. So it's not a pipe dream. It's not a throwaway catchphrase. It's actually real. And you see a number of things. You see in this image, you actually see the arc of calcium. We saw this in cases yesterday. That's detected by the AI. You see lumen detection with measurements that are done by AI as well. You also see length measurements. It's actually really cool, a system that you can use in that way. And the SpectraWave system also has lipid detection as well, similarly done in that way. So there's also going to be a lot of impact of this going forward. But as I said yesterday, I think that this new system, this new Ultreon 2.0 system is really, it's not your like standard iPhone upgrade that happens every year, every 6 months. It's a legitimately different system, and it's actually really, really good. So that's great. Now, similarly, about exactly the same time, there's also iteration on the IVUS side. And because with HD IVUS, you have higher resolution, you can actually do much better detection of not only the lumen, but also the media and the external elastic lamina. And this is the Avigo Plus system from Boston Scientific. You can see here, it automatically detects where the MLA is. It gives you measurements here. You can override these as needed. It gives you a length assessment as well. And although there's not real-time co-registration with it yet, this is actually quite nice to see. And once again, real-time application of AI. So I think, to sort of conclude, I would say that IVUS and OCT really shouldn't be competing, but they're actually complementary technologies. I think cases where OCT is clearly favored would be things like looking at ruptured plaque, looking at ACS types of lesions for morphology, et cetera. I mentioned before for IVUS, I think in general it's favored for low CKD or CKD patients, low renal function. Also cases of CTOs where you don't really want to pressure out of the lumen. But stent failure may favor OCT. And so I firmly believe these are all tools that you need. Obviously, the economics are tough for labs to figure out when you should buy one, when you should buy the other. But as we stated in our imaging recommendations, we really think you need to have both so that in that specific patient case, you can pick the one that you think works best. Obviously, you do want to try to not use more than one in a case because that really becomes difficult. But think about imaging when you do especially complex PCI, and I think you'll get your best outcomes that way. This is just sort of Margaret's slide comparing the various differences and strengths and benefits of each, I think explaining why they're complementary as a whole. And with that, I'll conclude. We're going to go back to a discussion. Maybe some thoughts, David, why don't you start? What are your thoughts on this in terms of these technologies? How do people choose?
Yeah, no, fantastic talk, Ajay. I don't know if you did that straight off the cuff, but it was brilliant. I mean, in some senses, the controversy here is more one step back, isn't it? Which is the sort of using intracoronary imaging or not. Now, pretty much everybody accepts that we should, but actually the practicality and the reality of it is that still the rates are relatively low. So I must say I would really agree very strongly with what you said at the start, which is that, okay, not everybody's going to be able to afford both OCT and IVUS in every lab. So if you can't do that, which many people will not be able to, pick the one that you have got the most initial familiarity with and get used to using it. So the key thing is use one of them, and get good at it. Yes, finer points, finessing which has benefits and strengths in particular lesions, yeah, that's fine. That comes later, but really we need to get up from the current 20% or whatever it is globally where there is intracoronary imaging. So I mean, I think the debate is great, but in a sense, the true controversy is one step further back.
Yeah, I think thank you so much for saying that and for grounding me as well, because I fully agree with you. The best way to learn something is not to keep dabbling between different things, is to learn something well, get good at it, and then go from there. I will say, maybe controversially, but I think it was fair to say that when in that document we published, we did say that if you can only have one imaging modality, and we were driven by the CKD population, we said that IVUS is probably the one, or HD IVUS is the one that you would pick. But as I said, I think OCT offers a lot of advantages, and so hopefully people get those skills quickly and then go from there. And maybe with the AI algorithms now, with Ultron 2.0, you could make the argument that OCT is easier to learn. So look, there's debate there. Joost, what are your thoughts?
Oh, I totally agree with everything that has been said. I think both technologies have their pros and cons, and I think the decision of whether to use either IVUS or OCT, at least in my practice, typically depends on the individual patient and lesion. You look at renal function, you look at anatomy, osteo left main. I tend to opt for IVUS. If there's ACS with lesion ambiguity, for me, OCT is the go-to technology. In general, I think IVUS is a little bit more universally applicable, but both, as you said, both have pros and cons. One final note from my side. I think this is a little bit of a short-sighted discussion. I think the future will move into integrated solutions, like now with the spectral wave system. You will get the penetration of the IVUS with near signal and the high resolution of the OCT in one catheter. So I think in 5 to 10 years from now, the discussion will be different, and we will no longer have this discussion, and we'll have tools and AI solutions that offer both into one product. At least that is my, it's what I think the future will head into.
I think those are great points. Holger, where do you sit on this?
Yeah, exactly. I can only echo what the others have said. At least we are in the lucky position that for sure in Leipzig, we are a high volume center. We have both imaging modalities. Maybe you can remember last year we have done a zero contrast PCI using IVUS. So this is for sure, as you mentioned, Ajay, if you have patients with chronic kidney disease, with severely impaired renal function, then the way to go is for sure is IVUS. But for sure, OCT also has its advantages, and you should be able to interpret both imaging modalities, and then you should use it specifically in specific situations when you really believe that this is a better situation than the other one.
No, I think good points. And David, again, I want to thank you for grounding the discussion. We can get very much up in the clouds at times. I think also we didn't talk about the meta-analyses and the controversies there because of Illumian 4, et cetera. I mean, my general take on this is that there are differences between the trials. Most of the trials will show in complex lesion subsets, true lesion subsets, not just patient subsets, that the imaging will help. I also think there are issues when you do imaging trials of sites that are very experienced or have a very prescriptive way of treating when they're using imaging. They tend to bleed that over when they don't use imaging. And so it also becomes harder to discern a treatment difference. But in general, now the data is moving in this direction. I have to give a talk next week at the ACC about, do I think imaging deserves a class 1 indication? And, in the past, I was hesitant because the studies were predominantly, Asia-Pacific geography only, not really more generalizable, certain really specific lesion subsets. But I think this year I'm going to say yes. I'm going to say I do think for complex lesion subsets, it should have a class 1 indication now with the randomized trials that we have. And I think that will make a difference for some of my colleagues who are in geographies where this is expensive. The guidelines make a big difference in terms of then justification of use of these technologies. So definitely more to come on that basis. I think we're going to move on now. Holger, we can give your talk. I think the camera issues have been straightened out. So this is actually a good segue because we'll talk about other ways to optimize PCI, and one of them is the pharmacology. So tell us a little bit about aspirin in all PCI, when, how often, when, doses, all of that. I'm looking forward to hearing this talk.
Yes, thank you very much. So I have to admit that I've been responsible, or partly responsible, for this part in the ACS guidelines of the ESC 2023. And we had lots of discussions on, do we need aspirin? Do we really need dual antiplatelet therapy for 12 months? As you all know, in the end, we decided that default strategy is still dual antiplatelet therapy in patients undergoing PCI, and also patients with a conservative approach in patients with acute coronary syndrome. Because at this time, I found it very confusing to overlook all the different trials that are available, and also the different trial schemes that have been used in the different trials. But I try to sort this out for you, and then we can discuss if you really need aspirin in all patients with PCI. So why are we using dual antiplatelet therapy, and why are we using it for 12 months? You all know that initially it was PCI cure, and then we also had the Plato and Triton TIMI-38 trials, which both showed with prasugrel and as well as ticagrelor in comparison to clopidogrel that this was better than the original clopidogrel. But the 12 months stem from the original PCI cure trial. And this is the reason why it is still in the guidelines that we should use dual antiplatelet therapy for 12 months. And there are some reasons why, at least for the first few months, maybe 3 months, it is reasonable to have dual antiplatelet therapy because we have local ischemic events, we have plaque progression, destabilization, in particular in the first 1 to 3 months. Bleeding also, nevertheless, is very high initially, and then it will be plateauing afterwards, as you can see it here. What is the rationale for aspirin-free strategies after PCI? So first of all, there are major uncertainties surround the use of aspirin for secondary prevention. then aspirin is inducing major bleeding, in particular GI bleeding and intracranial bleeding. And actual risk on the reduction on top of statins and newer antiplatelet drugs like ticagrelor is not completely sure. We also have some pharmacodynamic data of aspirin withdrawal, in particular if you are giving the patient with potent P2Y12 inhibitors like prasugrel or ticagrelor. And if you skip aspirin, platelet inhibition is clearly nearly the same with clopidogrel, with prasugrel or with ticagrelor. So this, from this perspective, would make sense to withdraw aspirin. Now we have to look into the trials. We have different trials. So we have a few trials comparing ticagrelor monotherapy after 1 to 3 months of dual antiplatelet therapy with aspirin plus ticagrelor versus aspirin plus ticagrelor. And we can have a look for all the different trials. So this is a nice summary from David Capodanno. So we have global leaders, we have Twilight, we have TICO, and we also have TPAS. And I will highlight TICO and Twilight and also TPAS. Also important for the interpretation and also for the discussion is that many of these trials have been performed in East Asian populations. So these were not typical US populations, these were also not typical European populations, as you can see it here. Once again, you can see these two trials were only performed in East Asian populations who are smaller, who have lower body weight, and who also have other pharmacodynamics in comparison to Caucasian people or people from all other parts of the world. There's a recent meta-analysis, individual patient data meta-analysis of TICO and also Twilight, as you can see it here. And as you can see here, altogether 7,500 patients have been compared for a shortened duration of dual antiplatelet therapy. And then aspirin was skipped with, and then only ticagrelor was given to the patient in comparison to the standard 12 months aspirin plus ticagrelor. And as you can see here, there's a significant reduction if you skip aspirin regarding BARC 3 or 5 bleeding without an excess in any ischemic events like all-cause death, MI, or stroke. So very recently also published, stopping aspirin within 1 month after stenting for ticagrelor monotherapy in comparison to the classical dual antiplatelet therapy in patients with acute coronary syndrome. Once again, East Asian population. And the median time for stopping aspirin was 16 days in the TPAS trial, as I will show you. And as you can see it here, NACE, so net adverse cardiac events, including bleeding, was significantly lower in ticagrelor monotherapy in comparison to ticagrelor plus aspirin, as you can see here. And interestingly, the two curves separated over time. This is very important also for the interpretation. And this separation was mainly because of bleeding. There was once again no excess in ischemic events in this randomized trial. So as you can see here, bleeding, no excess in ischemic events for these two primary endpoints. Next part, I would like to show you, it's not ticagrelor, it's only clopidogrel monotherapy after 1 to 3 months in comparison to the standard dual antiplatelet therapy. And once again, all these trials were only performed in East Asian populations. This is very important for the interpretation. As you can see it here, this is just on the summary slide. This is very important, in particular for patients with acute coronary syndromes. The stopping of aspirin 1.5 or 2 months after the acute event, as you can see it here, was not inferior. And very important, there was an excess in stent thrombosis in this trial when stopping of aspirin has been performed. Now, this is the summary: non-inferiority not met, more re-MI and stent thrombosis in patient with single antiplatelet therapy after early stopping of aspirin. Now looking for trials monotherapy without even any initial aspirin in comparison to dual antiplatelet therapy. This is also a trial which has been just recently published, as you can see here, Circulation 2024. Once again, East Asian population, Japanese patients with ACS or high bleeding risk, and they used a very loading dose of prasugrel of 20 milligrams with a maintenance dose of 3.75 milligrams, as you can see it here. This is a co-primary endpoint of bleeding. No difference between no aspirin at all with this low dose prasugrel in comparison to dual antiplatelet therapy. However, there was a trend for more stent thrombosis and recurrent interventions in those patients not getting any aspirin. And all the trials summarized on this slide, which is a very nice one. So this is stop-step 3. So no reduction in bleeding, but probably more stent thrombosis if we do not apply any aspirin at all. If we shorten it, the aspirin doses, we can reduce bleeding, and we do not have more ischemic events. For patients with oral anticoagulation, we all know that it's much better if we do not give any aspirin to these patients. There are some ongoing trials. This is very also important for the interpretation and also probably for what we are doing in the future. As you can see it here, there's a legacy trial and the new mindset trial where we can expect the data in 2025, 2024. You can see here, this is no aspirin at all at the beginning, and it's comparing P2Y12 inhibitor alone in comparison to the standard dual antiplatelet therapy. And the neo mindset is also very similar, only potent P2Y12 inhibitors, ticagrelor or prasugrel, in comparison to the standard aspirin plus a potent P2Y12 inhibitor, as you can see it here. So we have to wait for this data. And these trials are not performed, this is important, in East Asian populations. So this will give us more generalizability of the data when we have the data. So how we are doing it nowadays, at least in our practice. So in ACS, we, at least in Leipzig in Germany, we usually still have the 12 months dual antiplatelet therapy with aspirin. But for patients with high bleeding risk, we reduce the time with dual antiplatelet therapy. Also for patients with chronic kidney disease. So we are more doing an individualized approach for these patients, at least at my institution, and I know also in many other institutions, at least in Germany. With this, I would like to thank you, and I'm looking forward to the discussion.
Holger, that was a great summary. I think it's hard to actually summarize all the data because of all the differences in the trial designs and the populations, the doses, but you know, and especially to do it in a short period of time, and you did exactly that. So it's great to review for everybody. I think practice is not that dissimilar in most places. I mean, some basic themes, though, you highlighted was in that ACS subset. There does appear to be potentially an increased risk. We're actually going to see a trial at the ACC next week, looking at 1 month with a potent P2Y12 inhibitor, ticagrelor, in ACS patients. So definitely interested to see what those results are. Some of the issues with stop-DAP ACS, specifically stop-DAP 2 ACS, as well as the prasugrel study you showed, stop-DAP 3 are the dosing in the prasugrel arm, and then also the fact that in stop-DAP 2 it was clopidogrel. So perhaps with a more potent inhibitor, you don't have that variability. You discontinue the aspirin and you still get your bleeding reduction without an ischemic price to pay. But let's see what the results are. David, is there a way to summarize this for clinicians, or is it something we wrote an editorial, Roxanne and I, that the best choice of
I think it's pretty tricky, and I mean, David Capodanno's article in your intervention shows how complex it is, and Holger, showed that very nicely. I think there's no doubt that aspirin can be jettisoned in many of these settings. But there are a couple of practical, or at least pragmatic, concerns about this, and they relate mostly to what happens to patients as they get older. And there are two things that happen. One is they present for some other form of surgery, and the second is they develop atrial fibrillation. And both of those present a problem, or more of a problem, if you've got somebody on prasugrel rather than, for example, aspirin, or even perhaps clopidogrel, slightly less potent. So, you can end up, for example, in the bleeding risk front with somebody being on both an anticoagulant and a potent P2Y12 inhibitor, which is obviously substantially risky. On the other hand, you can have people who are presenting for surgery, and whilst many surgeons are quite happy to operate on patients on aspirin, they'll be much less happy on prasugrel. So you risk people simply being stopped or being given some complex bridging mode with either heparin, which won't be helpful, or a tirofiban or something like that. So although I think it's a perfectly reasonable strategy, and we will move towards getting rid of aspirin, we do also need to think of the parallel harms that may happen when patients are, if you like, out of our control, and other people make decisions about the tablets they're going to be given perioperatively or in the setting of AF.
Really, really important points. And I always worry about that, is that if they're off aspirin and then someone stops the other agent, they're basically on nothing. And
Exactly.
that can be a challenge. Joost, what are your thoughts on this area? And by the way,
very complex issue.
One quick thing.
Yeah.
I just want to remind the audience that poll is still open. So just answer the poll question while we're talking about drug-coated balloons, because we're kind of curious about that. Go ahead, Joost.
Yeah. So I think it's still a difficult discussion. I mean, from the Stent trials and everything, I think we learned that in patients who present with stable angina, I think it's pretty clear, right? After at least 3 months, I think there's no need for that. It only increases bleeding. And whether you should continue clopidogrel or aspirin, I think is still out there. In ACS, I think we now have a wealth of trials. Now, Stop That ACS is popping up at ACC, but here in Rotterdam, we're doing Compare Acute, in which we all tend to prove the same thing. After 1 month of DAPT and ACS, it's very likely safe to drop aspirin and just to continue with a potent P2Y12 inhibitor. The discussion then is postponed to 1 year, because what do you do at 1 year? Do you switch back to aspirin, or do you keep the patient lifelong on prasugrel or ticagrelor? So that's also, I think, a issue that we have not settled yet. And the third issue to me, which has not been settled, and that's where Holger nicely demonstrated, for instance, the Legacy trial, is there even a need to start aspirin for the first month in patients with ACS, and even in stable patients, but if you just start a potent P2Y12 from the beginning? Resolved in the coming years, but for now, I think within this maze of DAPT trials, I think the guidelines are pretty clear and solid, and a patient-tailored approach should remain key.
Yeah, the two other scenarios that I'll bring up that do happen in clinical practice are post-surgical. I think that there's, surgery is a pretty prothrombotic event. And I think early discontinuation, especially with clopidogrel, there are a lot of stents that have been shown to be safe at a month. I don't personally feel comfortable sending somebody for big surgery with 1 month of DAPT. It's elective, just in that way, because it's just more prothrombotic. The second thing that I'll point out is the clopidogrel hyporesponsiveness. Like, that's why all these studies are moving towards more potent agents, because you don't have the variability. But even in the situation where you're on triple therapy, we know it increases bleeding. But if you stop the aspirin and you happen to be a non-responder to clopidogrel, you're on nothing. And what people don't necessarily realize is that even in those studies, even in the meta-analyses, there is a signal of an increased myocardial infarction in the group that has full discontinuation, clearly a reduction in bleeding. But so we in our practice actually check platelet responsiveness before dropping the aspirin. It's not in the guidelines. It costs money, but especially for a higher risk patient, we found it to be pretty useful. Holger, you presented it so well. Where you talked a little bit about where this is going. Those trials are going to be informative and interesting. Any clinical takeaways? Maybe I'll ask the question because we talked about imaging before. Does it matter if the PCI was an imaging guided PCI? One of the things I tend to do is I always ask for the films and I look at who the interventionalist was that did the initial case, because that changes maybe what I think. I don't know what you think.
Yes, maybe it's easy answer. So in the moment when I'm using intravascular imaging, this is a complex PCI. And in this situation, I usually tend to give dual antiplatelet therapy for a longer time. This is the easy answer. And also, in particular, for patients with high ischemic risk, like patients with acute coronary symptoms, I usually tell the patient, usually you should take this for 12 months altogether. In case you have bleeding or any side effects of dual antiplatelet, then there is the possibility to stop aspirin after 1 month or maybe after 3 months. So this is at least what we advise the patient when we discharge the patient after an acute coronary syndrome.
Yeah, in New York,
I think we're actually testing that strategy of testing for clopidogrel responsiveness now in the COACH trial in Rotterdam, in which we enroll basically everybody that undergoes PCI and is already in need of either vitamin K antagonist or a NOAC. In those patients, we test for clopidogrel responsiveness, and we then, if the patient is a low to intermediate responder, switch to a prasugrel-based treatment strategy, and we're following all these patients to check for both bleeding and ischemic event rates. So also that trial will likely provide some guidance in how to handle this issue.
Yeah, one of our residents presented an abstract at the CTO Plus meeting where he looked at our experience and it showed, very good outcomes with it. And the good news is that because of the different doses of both prasugrel and ticagrelor, you can get with 60 BID of ticagrelor similar efficacy without the bleeding risk of a higher dose, and similarly 5 milligrams of prasugrel will do the same. So we often do that in those circumstances. In New York also, because we can get people who with interventions all over the place, for me it does matter who did the intervention beforehand, and I try to get the films, and hopefully there's some IVUS or OCT measurements, and based on that I might feel a little bit more reluctant or more comfortable discontinuing. So well, great discussion. Again, yeah, go ahead, David.
Oh, sorry. One last point. I think from our point of view, we also have to be mindful of what happens when the patients go out of our control, because they quickly do, and other people make decisions about their tablets. So we have to try not to make our regimes too complicated, both from the patient's point of view, but also from the point of view of the other physicians or surgeons who will end up stopping tablets when we didn't really want them to.
Really, really well said. Great discussion. Let's move on to the final talk of the session, and Joost, take it away.
Yeah, thank you, Ajay. So to me, this tough question, stent versus drug intervention in stable patients. I will try to set up the scene for the discussion a little bit by making some statements and then trying to answer a couple of questions. So basically, this is the problem, right? You have somebody with a completely or partially blocked coronary who is presenting you with chest pain, a syndrome and a symptom that all of us recognize in daily practice. And then the solution is simply drugs, right? I mean, all these patients get a decent amount of drugs, and then we hope, at least if they present with stable angina, that their symptoms will disappear. What most of us don't realize, and that is something that Ajay, you also one of the people involved in the RDN trials, we've learned to appreciate more and more over the last decade, is that patients often don't take drugs. If we look at trials, and this is just one published in Hypertension 10 years ago, publishing that non-adherence rates are reported to be up to 50%, irrespective of whether the patient is on beta blockers, calcium channel blockers, diuretics, etc. So that is a critical issue which needs to be taken into account for each patient that you prescribe drugs, because again, the patient is symptomatic and wants to be relieved of his symptoms. Now, what about revascularization? Obviously, two options, stents and CABG. In the sake and the interest of time and the topic, I will not dwell into the benefit of CABG, but focus a little bit on PCI. And then we have three outstanding questions. First, does PCI reduce ischemia? Second, does PCI improve symptoms? And three, does PCI improve heart clinical endpoints? Because these are basically, to me, the three questions that need to be addressed. So what about the potential of PCI to reduce ischemia? I want to take you back to the Courage trial. This is a sub-analysis that Leslie Shaw published already 16 years ago in Circulation, in which we looked at a subgroup analysis of patients in Courage that underwent sequential ischemia testing using SPECT, in which they were able to show that PCI resulted in a greater reduction in ischemia compared with optimal medical therapy alone. And in absolute figures, in the PCR arm, and bear in mind, these patients were mostly treated with bare metal stents, a 78% reduction in ischemia versus a 52% reduction in ischemia in patients on optimal medical therapy. So a clearly significant difference in favor of PCI in terms of the ability of reducing ischemia. This is some more contemporary data that Chris Cook presented in JACC 5 years ago, showing you that PCI removes the flow limiting effect of stenosis. So flow assessment and baseline and post-PCI clearly improved following stenting, which is conceptually logical, but in this case also nicely demonstrated in a paper with extensive coronary flow assessment pre and post PCI. Now, second question, does PCI improve symptoms? And that is a question that we need to address based on the ischemia trial. So no discussion about the topic without mentioning ischemia. As you recall, a large randomized outcome trial randomizing almost 5,200 patients on optimal medical therapy to either OMT alone or a invasive strategy with a catheterization and potentially a revascularization in a invasive strategy arm. Interestingly, I will get back to the clinical endpoints in a minute. All these patients within the ischemia trial were followed at 1 month, 3 months, 6 months, and then every 6 months thereafter for Seattle Angina questionnaire assessment and quality of life assessment in this prospective protocol. And what we learned, John Spurtis presented these results in the New England Journal of Medicine, is that Seattle Angina questionnaire summary scores increased 2.9 points higher with the invasive strategy than with the conservative strategy. So statistically significant, with a difference that was larger among participants who had more frequent angina at baseline. I say that because this result that is statistically significant, but if you look at the curve, relatively modest, should be interpreted in light of two findings and two issues actually. First, within ischemia, 35% of patients reported having no angina in the month before enrollment. So that dampened, per definition, the treatment effect. And the second thing that you should consider is that within ischemia, 79% of the patients in the invasive arm underwent actual revascularization, so 21% didn't. In the conservative arm, conversely, 21% did undergo revascularization. So this is, again, a piece of bias that may have dampened the treatment effect in favor of OMT. Now, ORBITA-2 was the double-blind randomized placebo-controlled trial designed to assess the actual effect of PCI as compared to no PCI in a placebo group and patients that were taken off anti-anginal medication, with a primary endpoint being angina at 12 weeks. So this trial, published in New England last year, concluded that at 12 weeks follow-up, mean angina symptom score was 2.9 in the PCI group and 5.6% in the placebo group. Again, statistically significantly better in the PCI group as compared to the placebo group. So again, proof of concept that PCI is able to reduce ischemia, improve flow, and reduce angina in a general population of patients presenting with symptomatic angina. What is a side note that I want to make is the fact that there's a harsh reality to all these figures. Because if you look into ORBITA-2, significant improvement of angina, but more importantly, 40% of patients in the PCI arm still had angina post-PCI. And that is something that is interesting and not such a new finding. Because if you go back to Courage, back to ischemia, in the paper of John Spurtis, the exact same figure was found. 40% of patients still had Seattle baseline angina questionnaire scores above 50, indicating that, again, 40% still had angina following PCI. So this is something that is important and addresses and raises the question, why is that? And there are numerous factors that have been proposed to be answering this issue. There are patients that actually have spasm, those who have myocardial bridging, residual flow limiting disease, etc. But what is important and something that you could actually see and treat as an operator is the fact that we send back our patients from the lab with an angiographically successful result, not knowing that 50% of them actually have suboptimal FFR figures. And if you would have looked with IVUS or with imaging in general, you would have found that more than half of your patients would have been sent out of the cath lab with residual proximal disease, distal lesions, residual edge dissections, or stent under expansion that was not clear on the angio, which means that we just need to do a better job in sending our patients home after PCI. Final question, does PCI improve heart clinical endpoints? We go back to ischemia. This is the result of the primary endpoint, CV death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. No statistically significant difference in the primary endpoint and a mean of 3.2 years. However, what is interesting is that you see the event curves crossing. Around 2 years after enrollment, the invasive treatment arm with the event curve start to deviate in favor of an invasive strategy. And if we dive a little bit deeper into that, it appears that this is due to the combined endpoint of CV death or MI, but more specifically to the occurrence of repeat myocardial infarctions that are statistically more frequent in the conservative arm as compared to patients who underwent an initial invasive strategy, irrespective of the MI definition that was used based on either CKMB or troponin. Final trial. So what if you would restrict your revascularization to patients with higher ischemic risk and more extensive coronary artery disease? This is some data that Kevin Bainey from Canada published, almost 10,000 patients from the Canadian registry. I think, Ajay, you were also part of that study, showing you that patients who underwent a conservative treatment had significantly higher event rates at long term as compared to those who underwent revascularization with no clear difference between PCI and CABG. That was due to all of the individual endpoints, death, MI, and CV death, but particularly revascularization rates were obviously statistically lower in the invasive treatment arm. So with that, I would like to conclude that PCI has the potential to relieve ischemia and improve outcome, however, only if properly done. And shared decision-making is key. This young gentleman may not make the same decision as to whether or not he wants to go under extensive stenting or drug intervention as compared to this elderly lady who's potentially less active and has a different bleeding risk, which may necessitate the need for DPT following stenting. Thank you.
Fantastic talk. I think you covered all the main issues. One of the biggest problems, and Holger, maybe I'll start with you on this, is that evidence-based medicine is no doubt one of the greatest contributions to scientific learning and learning in medicine, certainly over the last few decades. But one of the challenges with it is the interpretation, and everything is nuanced in clinical care, and yet oftentimes randomized trials will give you an average treatment effect for everybody that was in the trial, obviously not commenting on those that weren't in the trial. And so the conventional way of reading ischemia is that there's no benefit to a strategy of CAP. But yet, I think as you showed, there are, depending on who you are and what the anatomy is and all of that, most people, as we talked yesterday, don't even realize that there's a reduction in myocardial infarction at 4 years in the ischemia trial, despite the fact that there's upfront risk of myocardial infarction. So Holger, tell us, how do you think through this? Because you do so many randomized trials, and I know you hold yourself as a really, you're certainly well recognized as a world famous trialist, but how do you think about stuff like this when it comes to individual patients? You're on mute, I think.
Sorry. Always when I look to this data, at least my impression, and this is what we also see, is that probably the highest risk patients have been excluded from these randomized trials. So usually, because we believe that this patient will have a benefit, in particular patient with a proximal LAD lesion, this is often a patient who will not be randomized. And that's the reason why we always have a selection bias to the less sick patients, in particular these randomized trials with chronic coronary syndromes. And this is probably also one of the reasons why, at least partially, these results were neutral or negative. As you mentioned, so it's relatively clear that we can reduce recurrent myocardial infarction, but we do not know if we really are able to reduce mortality. Ischemia, this is also important when we interpret ischemia, is that ischemia changed his primary study endpoint because of the low event rates and because of the slow recruitment. I think this is also very important. If you ask me, it's still open if primary or PCI reduces hard clinical endpoints. For this, we probably would need a trial with 20,000 patients, not excluding the low-risk patients, the high-risk patients. But I'm not sure if this will be feasible to be done.
Yeah, I think the other thing that's important about ischemia is the ischemia extend analysis got published in Circulation, and they showed actually a reduction in cardiovascular death with the invasive strategy that was predominantly driven by those patients who had multivessel disease. The problem is there was an increase in non-cardiovascular death, and that's why all-cause mortality was neutral, although trended less with the invasive strategy. We'll see what happens with longer follow-up. Unfortunately, they ran out of money, so they couldn't collect MI for late follow-up, which is unfortunate because that would have been, pretty useful to detect. I also think that, remember, everybody in ischemia that got a CTA that was done blinded to rule out left main disease, and they found that in about 8% of patients. So it's not as simple as you have somebody with CCS syndrome and you just, take a high ischemic risk patient and just treat them medically. You don't generally want to do a CTA to make sure they don't have left main, is at least my take on it. David, what do you think?
Yeah, well, you've highlighted and you highlighted very nicely, some of the drawbacks of the ischemia trial. So, I mean, we won't go into that. It's a very frustrating trial for us in some respects. But I think what you showed really nicely is that actually you can just ask the patient, and mostly you will then get the right answer. Because some people will prefer the idea of a single targeted treatment to try and get rid of their angina, and some people will be quite happy to say, I'll take the tablets. I mean, they may take the tablets or they may not take the tablets. Obviously, we believe that a treatment that is not systematic but is targeted to what the target area is a better treatment. But the patients will tell you, if they want to have the angina relieving angioplasty, that's great, that will work for them. If they want to say they're going to take the tablets and said that'll work for them. And that's why actually seeing the patients is so important. I'm going off topic ever so slightly here, but I hate telephone follow-up. You just got to see your patients, and then you'll nearly always get the right answer for them.
Yeah, and I think so important points. Joost, your point as well about when you do the job, are you actually doing the job that you thought you did, is also really important. If you're leaving behind residual disease and not optimizing, then you're not really doing the job. And I think we know that this is not all microvascular disease. This is literally not doing the right job. And so, very, very
some of it, some of it probably is also, to be fair, patients are tricky, aren't they? And they say they've got angina, and it turns out they don't actually have angina at all. They have something else, but they think it's their angina. So that is a proportion of it as well. But no doubt there's inadequately done PCI, which was also partly responsible.
There's also the challenge of patients that they insist they don't have it, and then that day the spouse comes with them to the office visit, and they give you a completely different history. I always tell people that if the patient's spouse shows up with the patient, I know something's different, something's going on outside the.
That's true.
Joost, any final thoughts on this?
No, I think it was a great discussion. It's a topic, obviously, that we can dwell into for another couple of hours, but I think we touched a couple of very important points, and I think this closes the issue for now to me.
No, that's great. And so let's go to the poll results and see what that showed. I'm kind of curious to see. It was related to a different topic. We spoke about it a little bit yesterday, drug-coated balloons, and when do people use them? And it's a mix. I think it's a mix across the board, as we'd expect. This is exciting for the U.S. because we're finally going to have a drug-coated balloon in the United States. Obviously, outside the U.S., it's been around for a long time. There was a small randomized trial that in STEMI patients, that's just a research letter in JACC or JACC Interventions, I believe, looking at similar outcomes with DCB versus the DES in STEMI patients. We certainly need larger studies and multi-center studies in that regard, but there's a lot of excitement. So we may, once again, change how we do things on the coronary side. There's a lot of innovation, and we've seen this throughout the TIO meeting in the structural space, but there's a lot going on in coronary as well. So, and I think we'll see some of that next week at the ACC. Too. Any final thoughts? Each of you, maybe some brief words, and then we'll close it out and give it back to Nicholas. Holger, you want to start?
So yeah, for me, it was a very interesting session on all the controversies we currently have. I've learned a lot. Honestly, for many of the topics we have covered, I'm not 100% sure it will still be an individual decision on what to do regarding IVUS or OCT, when to drop aspirin. I'm a little bit more clear for me that PCI reduces angina, this is clear, but regarding hard clinical endpoints, this is still open, but we need more trials on this.
Yeah, 100%. Joost?
Yeah, you know what is so fascinating to me is that despite the enormous amount of evidence that we gathered as a cardiovascular community over the last decades, which is unprecedented and uncomparable to any of the other medical specialties, we still end with very relevant questions that change based on the things we do, the products we use, the aging of the population, etc. So we always keep finding new stuff to properly study and properly randomize controlled trials, and I think that is the interest of the field we are moving in, and that keeps me motivated. So I like the discussions, and onwards to next edition.
No, that's great. And David, final words of wisdom.
I'm not sure about that, but I'm going to end with something slightly provocative, which is I'm going to suggest that actually the drug-coated balloon story is taken so long to start taking off, but it really is taking off now. We've been using them a lot. We're very impressed with the results. I think in a few years' time, people are going to look back and see, wow, you put in metal stents, so permanent, lifelong metallic frameworks on the inside of these arteries. God, I can't believe we did that. And I think increasingly we're going to move to a situation where we only put a stent in if we really have to, and that primarily we try really hard not to. And that will deal with a lot of the issues we've been discussing in this last hour about prasugrel, aspirin, thienopyridines, etc., because you won't absolutely need the antiplatelet agents because you haven't got a permanent inflammatory metal structure in the arteries.
No, I agree. I think the challenge, especially in the United States, where there are a lot of low volume operators, is there's a real reticence to do this because you have to leave behind the result that angiographically might not look optimal. So we need the data for sure. It's hard to beat current generation drug-eluting stents, but I think that those trials are going to start coming out more and more. And it's for a patient, it's an attractive strategy because why put the metal in if you don't necessarily need it, especially when you know there's a continued accrual of events that happen over time.
Absolutely.
Well, thank you, everybody. I think it was a phenomenal session, and it's a great way to conclude TIO 2024 Volume 5. I really like the fact that yesterday and today on the coronary side, and even on the structural side, it was patient-oriented. We were really talking about patient risk, not just the lesions, not just what we see, and that's what clinicians do in clinical practice. You're interventionalists, but we're doctors and cardiologists first. So it was really nice to see that imbued throughout the meeting. There were a lot of themes that cross-pollinated beyond structural to coronary. The discussions were enlightening, and really thank the panel, world experts truly, and everybody eloquent, thoughtful. So Holger, Joost, and David, thank you. Sorry Margaret couldn't be here. She's still in the case. And I just want to thank everybody, all the organizers, Radcliffe, the sponsors. This event continues to be successful, I think, because of the quality of it. So that deals with all the co-directors, also all the sites, all the people working in the behind the scenes to make this happen. So really, really heartfelt thanks to everybody in that regard. And with that, we'll wrap up the session. I'm just going to hand it over to Nicholas for some final words.